And I want to spend some time talking about acute abdominal trauma, which there's very little information in your text about this. And the reason I wanted to talk about it is because abdominal trauma is the most common, potentially lethal type of injury, and it's frequently missed. Abdominal trauma is generally associated with certain other injuries, which we'll talk about in a little while. And the most common mechanism is blunt injury, which is basically where there's been a compression of the organs, usually against the spine, and it usually occurs with rapid acceleration or deceleration. For example, if the child is hit with an object, like let's say a bat, or if they're in an accident where they have a seatbelt on, then the acceleration or deceleration from the accident can cause the trauma. This type of trauma can lead to contusions, lacerations, or bursting of the organ itself. And the spleen is one of the most commonly injured organs. And the things that will usually cause this type of injury could be safety restraints, usually seatbelts in car accidents are a common cause, sports injuries such as hits to the abdomen in football with the helmet, bicycle accidents, generally the handlebars, and child abuse. And the reason for that is because this area of the body is usually hidden from regular view. So in this picture, this is a depiction of blunt trauma. You can see that in this picture it's a child in a car, and they have it against the steering wheel, but it could essentially be any sort of blunt force. It could be any object. It could be a bat, a dashboard, a fist, or whatever it is. So the force will come towards the front of the abdomen, and it will hit the abdominal contents, causing it to compress backwards against the spine. The compression can cause lacerations, hematomas, and you can see that the main part that's going to really receive the major injury could be in the back portion of the abdomen. So in other words, the parts of the organs that are closest to the spine in the retroperitoneal area, and so it can make it more difficult to actually see these. The risk factors in children are that they have thin, weak, and less developed abdominal muscles. Their chest walls are very pliable, so the ribs will not serve to protect things like the liver very well. They have very little subcutaneous fat, and they have less protection of the liver and the spleen with fat, muscle, and bone structures that we develop over time. Some of the signs and symptoms that are associated with blunt trauma, or abdominal trauma in general, are things like lower rib fractures, tenderness to the abdomen, distension, or if the child develops rapid shallow breathing, it could be because there's bleeding happening into the peritoneal space. And most of the time the signs are very subtle and they evolve slowly. So most of the bleeding that occurs in a retroperitoneal bleed happens in a longer period of time. In other words, at the initial presentation of the injury, we may not be aware how bad the injury is because the bleeding may not be really frank. Now, if they've done something like, burst their spleen, that's a different situation. It's going to be extremely obvious that that is happening. But for the most part, most of the time, it's contusions or small bleeds that are occurring in the retroperitoneum where it's hard to see them. Eventually, though, they will evolve into shock, signs of shock, lower hematocrit, pain, and abdominal distension. The other thing that most people are surprised at is exactly how much trauma can happen before we actually see any signs in children of abdominal trauma. So some common signs that we know about are for retroperitoneal bleeding are things like Cullen's sign, which you can see on the left, and that's just a small discoloration around the umbilicus. And then on the right side of the slide, you'll see Turner's sign, which is a large area of bruising over the upper leg and a side of the abdomen. But that is also a sign of retroperitoneal bleeding. Now, Kerr sign, that is left upper quadrant pain that radiates to the left shoulder. And so with splenic injuries, we look for things like left upper quadrant abrasions, contusions, amylase changes, changes like absence or hypoactive bowel sounds. Liver injuries are associated with right upper quadrant abrasions, contusions, and abdominal pain and tenderness. And there you can frequently see signs of shock because the liver is an extremely vascular organ. They will sometimes complain of referred right shoulder pain, and also they'll have changes in their abdominal girth. Their liver enzymes will also become elevated and their hematocrit may also drop. When there's a pancreatic injury suspected, usually pain is all over the abdomen. It's diffuse tenderness everywhere. There's frequently vomiting associated with it that's bilious and increasing amylase and lipase. In intestinal injuries, first of all, intestinal injuries are very suspicious because they're usually not accidental injury. There'll be a lot of pain associated with it that might initially be attributed to something like pancreatitis. They'll have bloody gastric drainage, so it could be coffee ground type of drainage coming out of their, through vomiting, for example, and an absence of bowel sounds. In terms of diagnostics for all levels of abdominal trauma, CT scans are, have pretty much become the standard because they can be done so quickly and they give a lot of information initially. The peritoneal lavage, that is another diagnostic method. We just don't see it as frequently now that we have CT scans. And what peritoneal lavage consists of is making a small incision, and this is done at the bedside, small incision into the peritoneal area, so the lower part of the abdomen, where sterile fluid, usually like an IV fluid, will be placed into the peritoneum, and then the tubing, after the fluid is infused, the tubing is placed sort of below so that gravity will drain out some of the fluid again, and we're looking for blood in the fluid that comes back. But unfortunately, it's not always positive when the person has bleeding. So because of that, it's less commonly used now. It also takes a little while, and the CT scans can be done quite quickly. CBCs are done. They're done serially because most of the time bleeding is subtle, doesn't happen all of a sudden. So you'll see the change in the CBC over time as their hemoglobin and hematocrit drop. We also do x-rays, generally chest and abdominal. And what we're looking for is not just looking for signs of the actual, ruptured area or injured area, but sometimes we'll see free air that's in the chest area or the abdominal area that shouldn't be there. So when they take the x-ray, they'll position the patient side-lying. And if we see air rise to the top into those areas, that lets us know that there's free air in the abdomen and something has to have been ruptured. We also do urinalysis, looking for blood in the urine, and ultrasounds, obviously, to try and see specific areas of injury. So the treatments, I would say one that isn't on the slide is just considering the possibility that the child could have an abdominal injury. That's a major one. In children, their abdomen is very small, meaning it's a small target area. So whenever an object hits their abdomen, the energy doesn't have as much of an area to disperse because the surface area of the abdomen is rather small. And so sometimes the injury will be large and internal, and you will not see outside injury. And what I mean by that is that you won't see things like bruising or contusions, but that should not fool you. So when we know about the type of mechanism that could have happened and looking at the signs that the child might have, it's really important that we follow up and even consider the possibility that the child could have an abdominal bleed. And that truly has been the main reason why children have died from abdominal injuries, not because it wasn't treated correctly, but because it was completely missed. So when I mean that you can't see some of the injuries, I mean that sometimes we'll get children that we know were run over, by cars, and we'll know that part of the area that was injured was their abdomen. They may have pretty massive injury, but when you look at the outside of their abdomen, they will not have bruising or tire marks or any of the things that you would expect normally. So that should not, you just need to keep that in mind. So vigilance is very important, frequently assessing the child, not just their physical assessment, but also changes in labs, so things like abdominal sounds, things like abdominal girth, doing vital signs frequently, always being on top of their airway, breathing, and circulation. We normally will put NG tubes if we know that the patient has no facial type of trauma and it's only abdominal. NG tubes are okay. If there is a suspicion that there could be any sort of facial trauma, then we do orogastric tubes, and that's just to decompress and remove air or other things that can collect, like blood, for example. And then basically the treatment is going to go one of two ways. It's either going to be surgical or it's going to be medical. And so the way that that works is that the preference definitely is to try and do medical treatment, which means things like bed rest and monitoring the patient, rather than trying to intervene by doing a surgical procedure. Surgical procedures are pretty much there for patients who are really severely injured, where the bleeding is so intense, so out of control, that if we don't directly do something, then it becomes life-threatening. All of these injuries, splenic injuries, liver injuries, for example, they're graded by severity. So when it's a low to moderate severe type of injury, we monitor it by maintaining the child in the hospital, doing the lab work, doing the assessment, rescanning them, looking for signs of change. If the laceration or the injury is too severe, where they have to have surgery, then obviously that's going to happen. But medical treatment, really decreases the risk of all the complications that occur with surgery. And so if possible, we will try and just keep them on bed rest and allow for the organs to begin to heal themselves rather than trying to intervene if possible.